So the IDEA category, intellectual disabilities, was formerly known as mental retardation prior to 2010. So in 2010, President Barack Obama signed legislation that required the federal government to replace the term mental retardation with intellectual disability in many areas of our government. So the measure was known as Rosa's Law, and it was approved unanimously by Congress before heading to the president's desk. And under that law, mental retardation and the term mentally retarded were stripped from the federal health, education, and labor policy, and intellectual disabilities and individuals with intellectual abilities were inserted in their place. The rights of students with disabilities remained the same, so there was no additional new rights that were granted for people with disabilities. What the law did was make sure that the terms that we used matched the times. IDEA defines intellectual disabilities with, there's kind of three prongs or three parts of the definition. One is that the individual has to have significantly sub-average intellectual functioning. And we usually determine that by using aptitude tests or IQ tests, and the scores that we're looking at for someone who may qualify for an intellectual disability are usually people that are scoring 2 full standard deviations below the mean, or about 2.3% of the population that take, when we look at IQ, the bottom 2.3% of the population. And we'll talk more about that and kind of what that looks like a little bit later. So there's this significant sub-average intellectual functioning. There's also deficits in adaptive behavior. And adaptive behavior is how well an individual functions in daily life. So whether that's vocationally, socially, educationally, across their daily life, with adaptive behavior really reflects what an individual's social and practical competence of meeting those kind of daily living skills, those daily skills to meet the demands of everyday living. So how well is this person actually able to live their life in new and different situations, and are they able to cope? And then the third component of the definition is that this category requires that it manifests during the developmental period. So the idea with intellectual disabilities is that these aren't really caused by some sort of trauma or disease that happens later in life, that it happens early on during during language development. So those are the definitions that we look for, and the criteria for that definition is these three different components. So for identification and assessment, we use a standardized aptitude test to determine intellectual functioning. So, if you do a Google search or something like, what's my IQ, or you see those Facebook quizzes or those types of things. There's a lot of different kind of little hokey or group IQ assessments that are out there, but there's really only a couple that actually meet the level of scrutiny to be used in schools. And so all of those aptitude tests that we use in schools they have to be normed on a very large population. They have to be reliable in that if you give them, time and time and time again, you're going to get the same results. And then there has to be some validity to what this concept or this construct that we really have of what intelligence is. So it's got to kind of match up with that. So most people actually don't have an actual standardized IQ test. A lot of folks call things IQ that don't meet that high threshold of reliability and in assessment. So again, it has to be one of these standard aptitude tests, and usually for people school age, most school psychologists use the WISC, or the Wechsler Intelligence Scale for Children. And again, we're looking at folks that are about 2 standard deviations from the mean. However, it's also important to know that aptitude test results should never be used as the sole basis when making decisions regarding special education services. So remember when we talked about multi-factored evaluation, you can't just use one test to base as your kind of sole criteria for determining special education services. So here is a picture of the standard curve, or what we call the normal curve, and so that kind of traditional bell curve that you see, and for many aspects or many attributes in our society, if you plot out across the population a particular characteristics, if you get enough folks, oftentimes you'll end up with a normal curve. So height is a good example. So if you took a whole bunch of people and you let's say men, took a whole bunch of men and you just plotted what their height is, you would, if you had enough participants, you would probably end up with this traditional bell curve for height. And the same thing's true for many other characteristics that we see in our society, that there's this mean, this average, and then you see a slow reduction in the number as that number increases, and you see a slow reduction as you go down from the mean as well. So on this chart, there are what the averages are for some particular tests. So the two IQ tests that we tend to see used in schools, and actually just used period, the two of the most standardized tests, the most kind of traditional IQ tests that we have available are, one is the Stanford-Binet, and that's been around for forever. It was the first of the IQ tests. And the second is the WISC, the Wechsler Intelligence Scale for Children, and that's the one that's most oftentimes used in schools. So you see that a score on either of those tests, 100 is average, and then you go out one standard deviation, both above and below the mean. So below the mean would be an 85, and above the mean would be about 115. And then two standard deviations would be then kind of 130, and scores above 130 is what we really formally view as gifted and talented. So if we're looking at kind of the standard curve, we know that about 2.3% of the population is significantly sub-average. So they're at about 2.3% of the population, and that's who we're looking at with intellectual disabilities for possibility of being identified as having an intellectual disability. And when we really look at gifted, we're looking at about 2.3% of the population on the high end of IQ. So people with scores over 130 is kind of officially what we really look at for gifted and talented. Of course, again, as we talked about, because there's no mandate from the federal government to provide educational services or to provide adequate assessment for people who are gifted and talented, there's oftentimes other scores that are used instead. So you can use a group score that maybe you give a test to the whole class and you take the kids who do the best in achievement, or even some organizations like Mensa, which is supposed to be an organization for people that are gifted and talented. The actual assessments that they use aren't, don't reach this level of rigor that we require for a true IQ. So there are these other kind of little assessments or books that you can get at Barnes and Noble, that are these kind of cheater IQ tests that are supposed to be give you a kind of a general score. Or again, like I said, some of those little tests on like Facebook and stuff like that, but they're not reliable nor accurate, and that we just don't get real regular scoring with those when we compare them to actual standardized assessments. So the classifications for intellectual functioning by measuring IQ scores, you'll oftentimes hear the term borderline intellectual functioning, and for folks that fall in this category, that does not qualify a student to receive intellectual to receive services under intellectual disabilities, but it's often one of the groups that are really at risk when we look at students getting services under IDEA. So again, people with IQ scores that are within 71 to 84%, they just don't qualify, and so it can be particularly problematic for students where you've got students that just miss qualifying under intellectual disabilities, but then um, you know don't necessarily qualify under another category, and yet folks still need help. So in order to qualify for intellectual disabilities, we're looking at scores, somewhere around 50 to 55, to about 70 is considered mild. Moderate is somewhere around, 35 to 55. Severe is 20 to 40, and profounder scores, usually below 25, is how we classify and how the Diagnostic Statistical Manual of Mental Disorders uses to diagnose, and World Health Organization too as well, looks at IQ scores and kind of qualifies them as to how we talk about folks whose IQ score, within this range. So it's important to realize that when we're using aptitude tests, or most people just call us IQ tests, that this whole concept of IQ is really a hypothetical construct, which means that it isn't something that can be directly measured. It's an idea. It's really a theory, in that we're not 100% sure what it means when people seem to be able to solve problems, particular problems really well. So we do know that IQ scores, people who tend to do well in IQ scores tend to have good problem-solving ability. They tend to have good verbal language skills, and they tend to be able to set up kind of approaches or tactics for solving kind of math and numeric problems well. But what that really means, what IQ means, is we don't really know what it is, other than it's just people who seem to have an easier time than others solving those sorts of problems. We also know that aptitude tests can only measure a student's performance at one point in time. So particularly the further students' performance is from the mean, the likelihood that when they're assessed again using a aptitude test, there's a greater chance for variance between the scores. So it's not uncommon, and I think people often don't truly appreciate that there are a lot of things, a lot of behaviors that we do that actually do change our aptitude scores across our lifetime. So there was a interesting study that looked at how IQ is affected when folks get a doctoral degree, for instance. So it goes up so many points for the average person who ends up, who was assessed when they were younger, and then they completed a doctoral degree. I think they were seeing the same thing with a master's degree, that once you complete a master's degree, people's IQ score actually increases. So some people believe that IQ is something that's truly fixed. So I heard I think one psychologist I've had, for class, used to think of it a little bit like having a measuring cup, where you've got kind of the lines on the outside, and it doesn't mean that people are going to meet their potential, but at least it provided, or it was his opinion that IQ provided a possibility of what potential was available for folks. And I'm not sure I really buy into that level of the construct. I think that that IQ is helpful for looking at how people tend to be able to, tends to give us a good indication of how people are able to solve problems, or likelihood of solving problems, how often they're going to have to have particular examples before they get certain concepts. I think it's really good at showing us those types of things. As far as metaphors about measuring cups or those types of things, I'm not too sure about. We also know that aptitude tests have historically been culturally biased, that there's been a lot of work done, certainly in the last 30 years, to curb some of those problems that we saw, particularly in the 70s and into the 80s, with having really culturally specific questions on the test. So, like for an example, on the WISC, there might be a question of what house is stronger. Is it a house made of brick? Is it a house made of wood? Or is it a house made of straw? And really what the question is getting at is, does someone know the Three Little Pigs story? And it really doesn't, it's really not a true, accurate assessment about kind of, we'd have to get into a much more complex conversation about kind of what is strength and what's better. So, for example, if you're on the Pacific Rim, where there's a lot of earthquakes, one might argue that a wood house is actually better than a brick house. So you've got to look at, some of these aptitude test questions are really culturally have a cultural bias and presume a certain amount of experiences that people have had in order to to get certain scores, particularly when we're assessing very young children. So aptitude testing also isn't an exact science, and we can see in order to be able to administer a aptitude test, you have to be a school psychologist or someone who's actually been specifically trained to administer one of these assessments. The challenges sometimes, though, is that sometimes assessors can both intentionally or unintentionally influence scores on by not following the testing protocols as to how the test is supposed to be given. And so we see sometimes a variety of, whoever's administering the test can really influence what the score is. Again, either intentionally or sometimes unintentionally if they're not well trained. We also know that aptitude scores should not be used to determine individualized education plan goals. They're really educationally irrelevant as far as telling us what a student knows and what a student doesn't know and trying to place them in curriculum. We know that aptitude scores should never be used as the sole basis for making decisions regarding special education services as well. We've talked about that already before. So when we look at assessing adaptive behavior again is this collection of conceptual, social, practical skills that have been learned by people in order to function everyday lives. So again, it's kind of this concept of how is this person doing in their daily functioning. And the adaptive skills exhibited by a person with intellectual disabilities are a critical factor in determining the supports a student may require to be successful at home or at school or in the community. And so, what level of support do they need in order to maximize their level of independence? We also, to actually measure, or the measurement of adaptive behavior is very, very difficult because it's so relative in nature, and social adjustments and competence are just hard to be able to pin down. There are some tools, some questionnaires, and some different assessments that we use, but oftentimes it's really just looking at how is the student able to function in everyday life, and what kind of skills do we need to teach in order to get them so that they are, so that they can adapt to these new social situations. Also, most instruments consist of a series of questions that a person familiar with the individual answers. So some of the assessments are just looking at having a caregiver really answer these questions rather than getting the answers directly from a person. And so there's a bit of a bias when we look at those types of assessments as well, because you're really not measuring the individual. You're not looking at the individual's behavior. You're looking at someone who's familiar with the individual to provide that information. So some characteristics of students with intellectual disabilities. There tends to be problems again with the concept of cognitive functioning. So whether that's memory, they may have difficulty remembering information, or learning rate, which is how many opportunities does a person need in order to learn how to do a skill? How quickly can they pick up new and novel skills? We tend to see that people with intellectual disabilities are well below that of typically developing students. There are aspects of attention. Oftentimes, students with intellectual disabilities are slower to attend to relevant features of a learning task that students without disabilities seem to be able to pick up on. So they may focus on the wrong aspect or the wrong concept when they're given an example, instead of picking up on what's the critical variable that makes this example different than other examples. Also, the concepts of generalization and maintenance. So having troubles with using new knowledge and skills in settings that are different from the context from which they were first learned those skills. So students may pick up a particular skill in a particular environment, but then when it comes to them completing that skill in a different environment, or where they may have learned the concept, but the actual how to do the skills actually changed a little bit. The antecedent, the prompt has actually changed a little bit. They may have problems. So an example might be, maybe you learned how to open a door using a round doorknob. Now, can you go out and generalize that with different doors, with being able to open and close kind of different doors? So that would be an example of generalization. Or maintenance is the idea that once you've kind of taught a skill, once someone shows the ability to do a skill, how long are they able to maintain that particular information? So just because you learned it once doesn't mean that you necessarily are going to remember that information into the future. So, so those are all some characteristics that are particularly challenging for students with intellectual disabilities, is they don't tend to generalize as well as students without disabilities, and they don't tend to maintain skills as well without practice compared to their non-disabled peers. So there also can be some motivational issues that are also a factor. So those inhibit an ability or lack of interest in learning or problem-solving tasks. Now, that seems pretty obvious, right? So if you have problems with learning, and learning's difficult, and you have problems with attention, you have problems with generalization, once you learn things, you don't tend to be able to remember them for long, or you can't use them in novel situations. It's hard to get really motivated about learning new skills and problem-solving tasks. So that one's probably more of a result of some of the other variables rather than a characteristic all on its own. So for adaptive behavior, we look at self-care and daily living skills. So can an individual who requires intensive supports, this person must be taught, oftentimes basic care skills. So when working with students with more moderate to intensive intellectual disabilities, we often see things like, teaching hygiene and teaching self-care, and a lot of the skills that we either learned as very little kids, or sometimes it's skills that we kind of just picked up on our own by watching our parents and watching others in our lives. These skills have to be taught oftentimes very directly. And so that's, so we look at, how safe is an individual on their own, what levels of supports do they need in order to be successful, and then we look at how that compares to typically developing peers. It also affects social development, so maintaining and sustaining friendships and personal relationships present significant challenges for many students with intellectual disabilities. We also see behavioral excesses and challenging behaviors, so they're more likely to exhibit behavior problems than children without disabilities. We may see them engaging in more repetitive behaviors or doing things over and over again than we see with children without disabilities as well. Some of the positive attributes is that you may display tenacity and curiosity for learning more than some other categories. There, even though motivation sometimes can be a challenge, there may be a real desire once they're into a task to really focus in and kind of complete that task. Also, for some students, they get along very well with others and are positive influences on others. So when we look at the prevalences and causes of intellectual disabilities, it represents a relatively and it's the fourth largest disability category, and represents, not that much over 5% of the total population of students with disability. Because again, what we'll be talking about next, learning disabilities is by far the largest category. And speech we're not going to talk about I'm not going to talk much about because most people are not receiving services by the time they get to high school. So as far as causes, we know that there are more than 350 risk factors associated with intellectual disabilities that have been identified. 35% of cases have some sort of genetic cause. Another third of cases involve some sort of external trauma or toxin. But the truth is that, for about a third of the cases, there's just no, there's nothing that we're able to identify as a cause or risk factor for students with intellectual disabilities. So for biological causes, we'll break them up into biological causes that occur before birth, during birth, and after birth. So some of the prenatal causes that we see of intellectual disabilities there are particular syndromes that that occur early on in fetal development that can increase the risk of intellectual disabilities. We also see that there are some chromosomal disorders such as Down syndrome or Fragile X that increase the risk of intellectual disabilities. There are inborn errors in metabolism such as PKU. I should probably say it. So PKU is phenylketonuria. Phenylketonuria. I'm going to have to go back and check. Phenylketonuria, I believe. And what it is it's a condition that it's not as big a deal as it used to be because it's now screened for as part of the screening that's done right at birth. But phenylketonuria is a condition where the body can't really break down a particular amino acid, and amino acids help the body to build protein in the body, and without treatment, what we see is that this particular amino acid builds up in the bloodstream and can cause health problems. So there are also developmental disorders of brain formation, such as anencephaly. That's a very very sad and painful disorder where a baby is born with pretty much just the brain stem. So cephaly meaning brain, ane meaning kind of without. So, life expectancy is very short, usually just a week or so with of babies born with anencephaly. Spina bifida is also a developmental disorder of brain formation that we see, and hydrocephalus. And you can probably figure out just by the word hydrocephalus meaning water fluid on the brain. So that all of those are developmental disorders in brain formation that can cause intellectual disabilities. We also see that there are some risk factors when we look at some maternal illnesses, and parental age are also factors that can cause or can be prenatal causes for heightened risk for intellectual disabilities. Also, maternal toxic exposures, so that having the mother exposed to substance abuse or environmental factors. So some disorders like fetal alcohol syndrome, or maternal exposures to drugs or other toxins, maternal malnutrition, radiation during pregnancy, all of those can increase the risk of intellectual disabilities. Some injuries that occur during birth that can increase the risk for intellectual disabilities. There are some intrauterine disorders such as maternal anemia or premature delivery, abnormal presentation, umbilical cord accidents, multiple gestations. So either having multiple births, certainly umbilical cord accidents historically have been where the infants' airway has been restricted, and they've um, been denied oxygen during birth is certainly a historic risk that we saw with intellectual disabilities. Now with and there's kind of a huge, I don't know about huge, but there's a lot of concerns about this. So, now what we see, particularly in American hospitals, is that, when there's any risk of abnormal presentation or the possibility of umbilical cord accidents, or you have multiple infants, they're much more likely to do a cesarean section. And so, what we see now is that there's there's some question as to whether or not the high rate of cesarean sections is really justified in the United States for infant safety, and that is a little bit outside of my area of expertise, but it is a big issue that kind of that is a big issue today, and you see it even in kind of modern hospitals. It's this because in many hospitals, parents are actually selecting the hospital that where they want to give birth, and so I'm always amazed whenever I go into some hospitals' birthing suites that they look very homey, and then but it's usually very easy, and sometimes the back wall will actually open up or whatever in order to move the mother and infant into a more if if surgery is needed. So it's interesting to see, and I'm sure the debate will go on with the number of cesarean sections that occur in the United States, and whether or not they're justified. There's also some neonatal disorders, so neonatal seizures that can happen during birth, or kind of aspects with meningitis, encephalitis, or head trauma during birth as well. So all of these are some causes that can happen really kind of at birth that can increase the likelihood of intellectual disability. And then there's some postnatal causes or risk factors. So we see some very early head injuries can increase the risk of intellectual disabilities. Also, infections. So, this gets into the the whole vaccination kind of stuff with we see with measles, mumps, and rubella can all cause a spike in body temperature, which can be a contributing factor for intellectual disabilities. Also, there's some seizure disorders. Now, most cases of epilepsy don't cause brain trauma, but there's a very small number of types of seizures that actually can cause brain injury as a result. So most seizures you see are that we see in epilepsy are fine and are and there's no brain dysfunction or brain problems, but there are particular types of epilepsy that can cause brain injury in itself, not from a head injury that occurred during a seizure. Also, we can see malnutrition can increase the risk of intellectual disabilities, and there are a handful of degenerative disorders that we see even for very young little kids. Usually when we think of degenerative disorders, we think of things like Parkinson's disease or things that happen later in life where that increase the risk of intellectual disabilities. But there are actually some disorders that occur across the whole lifespan. So when we get out of the biological and more into the environmental causes or risk factors, we see that psychosocial disadvantage occurs when there's no biological risk factors evident as a cause of intellectual disabilities. Then we start looking at the possibility of environmental causes. And so some environmental influences that may, I highlight this, that may increase the risk of intellectual disabilities include poverty and malnutrition, minimal opportunities to develop early language. We see sometimes there's, with a history of child abuse and neglect, increases the likelihood of intellectual disabilities, chronic social or sensory deprivation, lack of access to prenatal or birth care, parental drug use, or smoking. So, those are all risk factors for intellectual disabilities. Again, it's not a guaranteed thing. My mother was a smoker because it was back before we knew how what the effects of smoking was for infants, and I feel lucky to say I don't have any diagnosed intellectual disabilities. Parental immaturity or cognitive disabilities themselves. So if the parents have cognitive disabilities themselves, that can increase the risk factor for their children also having intellectual disabilities. Also, parental lack of kind of preparation for parenting, and kind of the inability to kind of take care of their little ones can increase the risk of children having intellectual disabilities. So we know that as far as prevalence and causes, we know 85% of people with intellectual disabilities are in the mild range. We've got over 250 causes of intellectual disabilities that have been identified, but 50% of mild cases and 30% of severe cases, the cause is actually unknown. So we've gone through a whole list of all these things that are possibilities, but with half the mild cases and in about a third of the severe cases, the truth is we just don't know. We don't know why why a particular kid has developed an intellectual disability and why another kid is not. So as far as prevention, the kind of the biggest game changer that we've seen for a strike against intellectual disabilities, I gotta fix that, I got MR there, is the rubella vaccine. So in 1962, we saw a dramatic change, a dramatic reduction in the cases of intellectual disabilities, where as the MMR vaccine was given, and rubella was the cases of rubella really stopped in the United States and in most of the Western world. Toxic exposure to maternal substance abuse and environmental pollutants are two major causes of preventable intellectual disabilities that can be combated with education and training. So we see things such as making sure that and this can come in a lot of different in a lot of different situations. So like I had a friend who in their family, the children were all there was a crib that was being passed down from generation to generation, and my friend had me come over and try to explain to their parent that this old wooden crib with like big slats probably wasn't the safest thing for a newborn anymore, and that even though it was okay in the 70s, and it was certainly okay before that, that we've gotten much more careful, and we've learned a lot more about childhood injuries, and so sometimes it just takes a little bit of education with folks, and that people think if that was what was acceptable when they kind of raised their kids, or when grandparents raise their kids, it sometimes requires a little extra education and training about just what what's considered safe kind of anymore. So although there's early risk factors and intensive educational services to high-risk infants shows promise, there's still very little or any specific widely used techniques to decrease the incidence of intellectual disabilities caused by psychosocial, disadvantage. So we know that in communities that are poorer, um, and particularly in urban, situations as well, we see higher rates of intellectual disabilities, and that, of course, is is a difficult battle to fight. So there's been advances in medical science that have enabled doctors to identify genetic influences early and earlier during a pregnancy. So we're going to talk about some of these on a separate slide. So like MSA-FP we'll talk about, and CBS we'll talk about on separate slides. But you can see that there's, that those are options, and amniocentesis is another option for high-risk pregnancies that we see. But we also see that we're, as advances in the genome, in the human genome, we also see that we're able to provide better genetic counseling to couples who are looking to conceive. And what genetic counseling is really a process by which the family who may be at risk for an inherited disorder are advised of the consequences and the nature of those disorders and the probability of developing or passing that on to their children, and so kind of providing them with options to them in kind of management and family planning around starting a family. Also, what's kind of interesting too is the newborn screening test for inherent and biomedical risk factors. And I find this personally just fascinating because it's the tests are actually, the newborn screening program varies pretty dramatically from state to state due to several factors. So like kind of what the laws are in each state, and what the state determines, like, what disorders are we going to screen for based on kind of financial costs of this particular screening. Also, they look at the frequency of disorders in a particular state, and the availability for treatment for each condition, which I find interesting that you would think about that. So if you don't have, I guess, available treatment for a condition, you don't want to screen for it, so that early. I don't know, but all of this is contingent state by state based on the funding sources for the newborn screening program. And so, what's interesting is just what is screened for based on the particular state in which you give birth. So like Washington screens for, I believe it's 29 conditions, but Oregon screens for 45 conditions, and California screens for, I think it's almost 57 conditions. And so each state really has their own kind of requirements about what they're going to test for and what they're not at birth. So the hope is to try to encourage more of a uniform and comprehensive newborn screening throughout the United States. So the Health Resources and Service Administration issued a report that recommends screening for, and they have kind of their top 32 specific conditions that are known as the core panel or uniform panel. And so what we're seeing is slowly states starting to standardize a little bit what they actually what they screen for at birth. But I know for me, when I found out about that, I just thought that was crazy that it completely depended on what state you're in as to what what testing's done on the newborn. So again, I don't think anybody finds that interesting but me, but I find it fascinating. So the MSA-FP is a screening test that examines for levels of alpha-fetoprotein in the mother's blood during pregnancy. So it's a blood test. And it's part of what's called the kind of triple screen that is oftentimes given to pregnant women. And the purpose of it is to really assess whether further diagnostic testing may be needed. So it's not a affirmative test. It just is a, lets both the physician, and so that the physician can tell the family whether additional genetic screening may be warranted. So, but alpha fetoprotein it's a protein that forms in the liver of the fetus, and it ends up through so then the fetus, it ends up in the amniotic fluid, and so then it ends up it can be detected then in the mother's blood. And so like high levels may indicate problems like anencephaly, like some brain function, or aspects like spina bifida, other disorders. And low levels might show chromosomal abnormalities like trisomy 21, which is Down syndrome, or trisomy 18, which is Edwards syndrome. So again, it's used just kind of as a general screening tool, but it's not a diagnostic tool. So if blood tests determine that there is a heightened risk for chromosomal disabilities, or there may be some other some problems with the fetus, chorionic villus sampling can be used to find some genetic disorders such as Tay-Sachs disease or hemophilia. It can also provide a more definitive determination for chromosomal disorders such as, Down syndrome. And what CVS really is it's it's this prenatal test in which samples of the chorionic villa is removed from the placenta for the test. So during pregnancy, the placenta provides oxygen and nutrients and all the things that the baby needs to grow, but it also removes waste and products from the baby's blood. And so what the chorionic villa are these little like wispy kind of projections, kind of like little fingers that kind of hang down from the placenta, and they share the baby's genetic makeup. And so, what they're doing is going and then harvesting one of these, kind of little finger-like projections in the placenta. And so for CVS can be done earlier than amniocentesis, so at like 10 or 12 weeks, where amniocentesis is usually done from 15 to 20 weeks. And again, this would only be done that if that's what the mother wants, and usually either in when there's been some concern based on one of the blood tests. So I've spent all this time talking about all these possible causes and what are some of the kind of early detection ways to be able to determine some of these disorders. But I want to get back to kind of what does this actually mean for us as teachers, when you're looking at working with kids with intellectual disabilities. So some of the characteristics that we see with students with mild intellectual disabilities are usually the fact that they have an intellectual disability is not identified until school age. So they're at age 6 or older before the school even is able to identify that they actually have a disability. Also, most students are able to master many academic skills, and most are able to learn job skills well enough to support themselves independently or semi-independently. For students with more moderate intellectual disabilities, we see that oftentimes we pick this up during preschool. They show significant delays in development during those preschool and kindergarten years. And then as they get older, the discrepancy in age related to adaptive and intellectual skills widens. So what that means is as we all age through school, we see that if folks start to fall behind at a young age, the chances are, without remediation, that the distance in skills between that student and their peers is going to widen as they get older and older and older. So we see this with moderate intellectual disabilities where they may not appear in preschool or in first grade, the difference between the skills of that child versus their peers may not be that vast. But that's just because they're really young and they haven't learned as many skills yet. And what we see is that as folks get older and older, and again without some sort of very intensive intervention, what we see is the skill gap just increases and increases and increases as they continue their way through school. So with students with moderate intellectual disabilities, this is kind of what we see, and this is what you'll see in the video. I would imagine Peter in the video that you'll be watching later probably scores in the moderate range for intellectual disabilities, either moderate or severe. I can't remember what, but he's in kind of this range. So again, then with students with severe intellectual disabilities, it's usually identified right at birth. Most have significant central nervous system damage and oftentimes are likely to have healthcare problems that require intensive supports across their life. So again, remember that we're talking about a very small percentage of students because most students have mild intellectual disabilities. And for folks that are in this range, we're looking at IQs below 20. And when you get to those very low IQs, it's not that folks just are not answering very many questions, that there's a certain amount of IQ points that folks get just by being able to support your own head, to be able to sit up and support your own trunk, and those types of things that are more kind of neurological based responding. Also, we count towards IQ points. So when we're talking about someone with an IQ of 20, we're not talking about somebody that is where they're answering questions or talking. We're looking at, is the person able to track with their eyes food or track an item. So again, we're talking oftentimes about folks with very significant disabilities in that severe and then or what's oftentimes called the profound range. When we look at educational placement alternatives, we know that about in the Heward book, the last numbers they give are the 2008 to 2009 school year. It was about 17% of students with intellectual disabilities were educated in the general education classroom. So quite a bit lower when you look at that big original pie chart from the first lecture. Many are, less than 20% are receiving services in general education. And this is important to remember as you watch Graduating Peter, and that in those early around 5th grade, 6th grade and stuff like that, he's full-time in the general education classroom and he's just receiving some pull-out services. Well, as you see he ages, he no longer is receiving services in as many services in general education, and he starts moving more into what we would think of as a life skills classroom in Washington State, where he's receiving more services with other students with disabilities and having fewer educational opportunities with his general education peers. So again, 17% are receiving services in general education. Now again, that's K-12, so the numbers are going to be even smaller for general education when we look at middle school and high school. 27% were served in resource rooms, and about half were served in separate classrooms. So remember that the difference between a resource room and a separate classroom is just what percentage of the day the student is outside of the general education class. So when we look at resource room, it's less than 50% of their day is less than 50% of the day they're receiving general education classes, and that includes electives and specials and all that stuff. Where 48%, about half, are receiving more than 50% of the school day just in special education without general education peers. And then 7% are educated students with intellectual disabilities are educated in separate schools, residential facilities, or hospital and home-based placements. And you can see that with students certainly with more severe and profound disabilities, that sometimes a hospital or more restrictive placement, particularly if they have, as their medical needs increase, sometimes they end up in more restrictive placements. So for most of the educational approaches, once we really kind of focus on these life skills or these adaptive behavior skills that we were talking about earlier. So like what skills is this person going to need to help them transition into adult life into the community? So, we look at things such as, interacting in the community. Are they able to, feed and take care of themselves and clean themselves? Are they able to cook? Are they able to engage in all those activities that most of us kind of pick up at home? We may provide more structured educational opportunities for those kind of life skills. Toileting is another big one. So, I used to work with students who had profound, more moderate to profound needs, and so I'd have a lot of friends that would ask me, it's like, well, gosh, how can you work with folks that have where their learning is so slow, and that and it kind of offended me at the time, because I'm not a real patient person, and so what I would see with a lot of students is that they would make great gains, but it's just that the gains that they were making were gains that we just don't have to teach directly to people without disability. So, for example, when I would teach a person to toilet themselves, I was saving the state of California something like $50,000 a year for every year of that person's life, because it costs about $50,000 a year to get enough coverage to get somebody who's willing to toilet an adult. And so just making these little things, even though made huge differences for a lot of students. So if they were able to toilet themselves, they could be in less restrictive kind of group home situations or adult living situations when they aged out and moved away from home. So just because they weren't reading the great American novel doesn't mean that the education that we're providing wasn't very, very valuable, and that there wasn't an actual significant tax savings for everyone in the community. And I think that's one of the really frustrating things when we look at students with disabilities, and that we oftentimes place whether we mean to or not, we place a lower value on certain folks, and then we place a higher value on other people. And I was watching, this last week, I was watching a rerun of Law and Order Special Victims Unit, and it kind of, bear with me, it goes to my point, where in the show there was a little girl who was killed, and something awful happened to her, and it was kind of written off, or the purpose of the show was to kind of tell you, it was just kind of written off. It was just another little girl from the urban urban New York, and then it comes out that she was some sort of very gifted violinist. And so, there's this, the show's kind of setting you up in that, now, of course, we're supposed to care more, or that, that people cared more now that this, this kid was gifted than we were supposed to care if if it was just another little girl of color who was killed in an urban setting. So I really want to kind of challenge you that, when we talk about things such as intellectual ability and about being smart, and about those and about giftedness and academic skills, we have to remember that when we really kind of put one up as higher or better, what is that really saying about folks who's that don't necessarily have those skills and may have different skills, and is their life then more or less meaningful? I hope not. I hope that we all are, as human beings, we have the right to, to respect and to dignity in our lives, and it shouldn't matter based on our kind of academic or um, abilities. So anyway, I went off topic just a little bit, but we do tend to focus the curriculum for students with intellectual disabilities, particularly on life skills and making sure that they're able to be as independent as they possibly can be when they reach adulthood. Another thing that we focus on is self-determination. And self-determination, we really work with students to have them set goals and plan and implement a course of action and evaluate their performance and make adjustments on their goals based on how they're doing. So again, these focusing on this idea of goal setting and being able to kind of self-monitor your own kind of progress towards your personal goals. And then we also spend time on functional curriculum. So what we do is that we take we figure out, okay, what are the skills that this student is really going to maximize, that's really going to maximize the student's independence or self-direction or enjoyment in school, home, community, and work life. So, we may decide that, the curriculum for this grade is, is just not really going to meet the needs for this particular student. So we may want to focus more on a different strategy or different activities that we know that the student's going to be able to maximize across their lifespan and not just going to be a skill that they're going to use just right now that they're in school. And this is the end of the book part of talking about intellectual disabilities. And now we're going to move on to a little different topic.